Welcome to PH Insights presented by the Pulmonary Hypertension Association. Join us as we delve into patient stories, healthcare updates, and the latest insights on pulmonary hypertension. Hi, my name is Angela, and welcome to PH Insight. Today, we are going to discuss transplantation as a treatment option for those living with pulmonary hypertension. Joining me to discuss this topic are two very important guests. Diane Ramirez, who is celebrating a year post-transplantation surgery, and Dr. Jordan Whitson, who led the team treating Diane. Now, I'd just like to take a moment to welcome them and allow them to fully introduce themselves. Dr. Whitson.
Yeah, thanks. So I'm Jordan Whitson. I'm an assistant professor of medicine at Duke. I originally hail from the Midwest, Kansas City, Kansas, and did my medical school and undergrad at Creighton University in Omaha, Nebraska. I moved over to do residency and fellowship at Indiana, and then I've been here at Duke since 2017. So I do lung transplant and pulmonary hypertension here, really involved with the heart-lung transplant program here. And I met Diane formally, I think a little bit before her transplant back in summer of 23. So I heard about her plenty from Dr. Fortin, who's one of my partners on pulmonary hypertension. So as luck would have it, I was on service when she received her transplant. And we've been working together since.
Thank you, Dr. Whitson. And Diane?
Hi, everyone. I'm Diane Ramirez. I am Dr. Whitson's patient. I had pulmonary hypertension for a little over 36 years when I had my transplant. I had a heart and lung transplant on September 13th of 23. So, yeah, everything has been going really well. I'm still very much involved with PHA. I currently serve on the board of trustees. I'm a support group leader and helping, hopefully, to get some transplant programming set up with PHA now.
I want to thank you both, but I also want to mention Diane is everywhere with PHA. We definitely appreciate you leading the charge on the resources we have available on transplantation. I think it's very needed. And of course, Dr. Woodson, thank you so much for being here and having this conversation. And I will say that it's come up in many other conversations on this podcast when we talk about pulmonary hypertension and the associated conditions. So thank you again both for being here. So one of the things I think just to start this conversation, I'm sure like myself, there will be many people listening who truly want to understand the transplantation process and also learn if it is a treatment option that they should discuss with their medical teams. When I hear transplant, I know there are different options out there, but when you think about pulmonary hypertension affecting the lungs, I naturally assume it would just be a lung transplant. We heard Diane had a heart transplant as well. Dr. Whitson, could you explain the transplantation options that are available for pulmonary hypertension patient?
Yeah. So when we talk about transplant for pulmonary hypertension, in my mind, it indicates the disease has progressed such that we have no other medical options. If someone is on IV therapy or inhaled or pills, that kind of thing, or both, and say doses are as high as we can safely go, there are no other non-surgical interventions, then that's usually the time we consider transplant. So it's typically an if all else fails sort of scenario. And here at Duke, so we'll do single lung, we do double lung transplant, and occasionally multiple organs. So we will do heart and lung. That's the most common that we've done. Lung and liver and lung kidney as well.
And you mentioned there are different options and you have to determine what's best for the patient. It's usually after other therapies aren't as impactful. What is the evaluation? How do you get to that point to determine that for a patient?
So most of the time we'll do double lung transplant. What we know and what we've learned in the past 20, 30 years since transplant has really taken off as something widely available is that double lung transplants do better long-term than single lung transplants. So a single is maybe less than one in every five transplant worldwide. And a lot of times when we talk about single and double, it's dictated by maybe the size of the chest, or if someone has cystic fibrosis, where the goal would be replacing both infected lungs, or something like pulmonary hypertension, where replacing just one lung wouldn't fix the very high pressures going from the heart to the lungs. And so just like the idea of medications, transplant and pulmonary hypertension, it's that when the disease is removed, the pulmonary hypertension goes away and the heart will eventually return to normal. But if somebody has had pulmonary hypertension for many, many years, and sometimes in the order of decades, it may be sort of stuck like that. And so a heart transplant will be necessary because the heart may not go back to normal. And as Diane can tell you, the transplant process is very involved. So we have everything from surgeons to nutritionists to pharmacists before and after. So crossing every T and dotting every I, make sure it's a safe option. So if somebody, for example, is extremely malnourished, has really poor kidney function, or very difficult to treat infections, you may worry that a major surgery and then suppressing the immune system will hurt them rather than help them. And so the typical process, it's a huge team of, I mentioned the surgeons, the pharmacists, you have financial help, social work, psychology, psychiatry, and it's just a multitude of tests to, again, in my mind, make sure that it's a safe option. And if it's not at the moment, can we make it a safe option?
Yeah, that's definitely more involved than I originally thought when, even preparing for this episode, Diane and I met to talk about all things transplantation and some of the things that she had to navigate leading up to the process as well as afterwards. It just blew my mind. And Diane, you lived through this. So can you share a little bit about the process for you?
Well, the evaluation is really intense, and that's putting it mildly. It's really hard to put into words. I had to go initially for the 2 day, and the transplant team met and then set up the full evaluation. So then I had to go back for another 5 or 6 days of testing. And they do test everything. You do meet with numerous people, like Dr. Whitson said. And it's, one appointment after the other, very long days, a lot of information. I was really glad that my husband was with me because he was taking notes. There's no way I would have remembered even half of what they discussed because it's just really a lot of information. Some of it's really heavy. So it's just be prepared for long days. The determining factor for me to go forward, Dr. Fortin and I had a couple of conversations, and it was getting worse, even though my pulmonary pressures didn't seem to be going up. There were other things happening with my heart and pulmonary artery. And, basically I just decided I wanted to live longer. And, after the conference in Atlanta, I came home and called Dr. Fortin and told her to go ahead and put the referral through to the transplant team to be seen. And here I am. Everything happened really, really quick once the referral went through. I went for the 2 day at the end of October, and November I had the full evaluation. And the first week of December, they called to say I needed heart and lungs to get there as soon as possible. So it was, a matter of a couple of months once the ball started rolling.
And for reference for those listening out there, the PHA conference in Atlanta was in the summer of 2022. So about the end of 2022 was when you received this information. And so it was pretty swift, like you mentioned, and there were a lot of factors going into it, a lot of things to consider. And when we were talking about this for the PH community, Dr. Whitson, what are challenges that people should consider when moving forward with the transplantation process?
So the one thing I'll say is every center is a little different. Here at Duke, we have pretty intense pre-transplant rehab program where we'll have folks relocate for a number of weeks beforehand and then complete the same number of weeks afterward, going through a lot of meetings with some of the surgeons and pharmacists before and after. So it comes off feeling a little redundant. There's a method to our madness, and at the end of it all, good rationale. The difficulty with pulmonary hypertension and transplant is that historically outcomes over the first year are the worst. Now, this is improved significantly over the past 10, 15 years as we've learned that those pressures in the heart that I was talking about before don't go down magically overnight. It required a lot of support. So we've employed a machine called ECMO. It bypasses the heart and lungs when they don't work on their own, and that's helped things tremendously. And really 15, 20 years ago, we didn't use that very much at all. And so as that has improved, we're not seeing as much of the immediate difficulty. But I think with pulmonary hypertension more than any other disease state, that the rigors of that kind of care, managing IVs, oral medications, it's really good training, I guess you'd say. Those folks with pulmonary hypertension come in almost with a leg up compared to others.
As I'm hearing this, and I know Diane's story, which we'll get to a little bit more as we move forward in this podcast, but as I'm hearing this information, while that process for Diane from PHA's conference in Atlanta to the end of the year went fairly quickly, after that process, there were specific things and pieces of information that you needed to know, Diane, as a patient to kind of prepare and get started. It was a very intensive program leading up to your surgery. So knowing these challenges and knowing all of the time and the effort to give into it, can you speak to how you prepared yourself for this?
When you're going through the evaluation, one of the things they have you do is go to the cardiopulmonary rehab center and meet with them. And they gave me a handout of the expected exercise that their program had and what they expected of me as someone going through the program to be able to do. And when I saw it, I just thought, no way, can't do it. I'm not well enough to do it. But, I'm an overachiever. So when I came home, I looked at that paper and I started making sure, no matter what, that I was walking every day on my treadmill to try to do 20 minutes, even though it was difficult, to try and build up some stamina. And I talked to a lot of people, my family, close friends, a lot of prayer, a lot of meditation, because I knew that there was a massive change coming and that my life would not be the same. I didn't know what it was going to be like because you just don't know. You prepare for the worst and hope for the best, right? So hoped everything would be good and that I would be able to move forward and continue living life. But we didn't know what complications could arise. We didn't know what it was going to be like to live in Durham. We didn't know Dale's job status, how that was going to work, what the financial costs were going to be. But then came the issue of like relocating, finding a place to live and covering those costs as well as our costs at home. We did a fundraiser. We talked to a lot of people and everything worked out. We were able to relocate in March and I started the rehab program. We lived, in Durham, not far from the hospital. We did find a place and worked with some wonderful people who work with transplant patients with living arrangements. So there's a lot to prepare for physically. There's a lot to prepare for emotionally. Your caregivers have to prepare. And I had 3 caregivers. It was like a caregiving team and, they have to be ready. I'm the one waiting for the call and they're waiting for me to call them and let them know I got the call, so everybody's on pins and needles. It was 4.5 months for me. So it felt like forever while I was waiting. But there's a lot of prep and you just have to do it a day at a time. The rehab program, they want you to do like 28 sessions, I think. And I would just go and, if it was a Monday, be like, okay, I'm just going to do Monday because the thought of having to do that much exercise every day for the rest of the week was overwhelming. Or to get through a month of it in order to be listed was too much. You got to break it down into small increments and deal with each increment when you have the energy to. That's the best way for me. That's what works for me.
Kind of want to recap, so to speak, what you shared there, Diane, because I think it's really, really important to note. Not only did you have to maintain a home at your home address where you lived with your family, but you also had to relocate closer to the center where you receive your transplant. And it's a lot if you don't live near where your transplantation is taking place. And what does that look like to raise the money, have that support system? Because you may qualify from your healthcare team's perspective, but can you sustain life or can you afford once you are in that qualification process? I think that's interesting to know. I don't know if that crosses people's mind when they're thinking about, oh, is this an option for me? And I wanted to highlight and point that out. How do you say we have to move and we have to completely uproot our lives? How do you have that conversation?
Well, I didn't say it. The social worker said it. And he and I were both actually quite shocked. So that's one of the things with Duke. When you meet with social work, they tell you what it is you have to do. So, she's like, we really ideally, because you're going to be here longer because it's heart and lungs, it's a longer wait. You should raise $15,000 to $20,000 before you move. And here's a list of places you can move to. These are some of the requirements for these places. And, I by that point, I was just numb. I was just taking the paperwork. I was like, okay, let me put this in this folder. This is going in that folder because it was just really overwhelming. They also give you the name of a group on Facebook that is just for transplantee patients. So I, joined the group, was able to pick the brain of other people that had gone through the intense program that I was getting ready to go through. And that helped a lot, talking to other patients that had been through it and what they had done. Ultimately, we went through the list of places to live. I made a lot of phone calls, and we just opted to go with a place that was already furnished. The rent included the utilities, so we didn't have to worry about deposits, setting up new accounts, and all of that stuff. There are a lot of different ways you could do the relocation if you're in an area where you have to relocate. Some places you can rent a room and share a kitchen. Other places, it's its own standalone unit. Other places are houses or townhomes. It just depends on really what you can afford and what it is that you need in the area that you're moving to. So, the social worker going over all the information, I have to say I wasn't happy and I didn't like her that day at all. I do not, see her and I give her a hug and, she was just doing her job, but I left the office that day and I was like, what is up with her? I really she was giving me information I didn't want to hear. So I copped an attitude, but the information had everything that we needed to make those decisions. So ultimately, I'm very grateful for all that information, but it was a lot. It was a real lot. And Dale and I just looked at each other, eyes really wide, like, oh, here we go. This is huge. And many conversations followed after that one visit. Yeah.
Yeah, it's definitely something to be prepared for and mindful of. And I'm sure your social worker knew anger that was going to come, but then the joy after, the process is done and over with and that you would connect. Like Dr. Whitson said, it takes that whole team. You have so many people involved in this process. And so you go through starting the process, you decide, yes, I want to move forward with transplantation. You're approved, this is what you're going to have. You have to move to this area. And now you get to the day of surgery and you are preparing. Dr. Whitson, what does that look like for not only your medical team, but for the patient? What is that preparation like for surgery?
So I guess I would say start the preparation as soon as someone makes it to that, what we call the relocated phase. And that's starting that rehab. So start what are called listing plans, and that's making sure all the medications we have a plan for the day after, what's going to happen in the operating room, what sort of medications does someone need at that time. And so we have everything down to the hour as much as you can. Now, we can control so much. And I think the biggest question mark, X factor, whatever you want to call it, is when an offer might come available. And so we have people, initially it was when was very first here, was people had to live 30 minutes from the hospital before and after. Now it's just after. I think we have people up to, I've heard, an hour and a half and 2 hours. So there's a lot of lead time for, but I'm not sure, and I'll tell folks this in the clinic, that if I could have a 2 or 3 hour visit, and I'm not sure I could tell you enough to really prepare you, because there are those sort of intangibles and things that I don't even know if I could opine about, the anxiety beforehand and the anxiety of the partners, family, friends, etc. And so how do you prepare someone for a 7, 8 hour surgery that you can imagine it's very involved? You're placed on that ECMO machine, and then there's this period of time afterward where someone is hooked to 2 to 3 different machines, keeping them alive or giving blood products and fluids. In an ideal setting, we're able to wean that support off over a day or two, and people wake up, they're reunited, I guess I'd say, with their loved ones. And that's a really fun moment. But, it's also the surgery itself. So there's pain afterward. We have a pain team and anesthesiologists who are very good at walking that line between pain management and going overboard with too much sedation. Or we have epidurals and pain pills. There's a lot going on in the background. Day right after surgery, transitioning IV medications to then by mouth, and taking out chest tubes and getting all the medicines to put the immune system to sleep, not totally knock it out, but drop it down. So 3 to 4 weeks is usually what I'll quote people in the hospital, but it's variable. Slowly but surely, there's this resumption of regular life. There are definitely things that can't be done afterward, like, eating sushi, mostly, like anything raw, I guess, unless it's cooked sushi. I'm swimming in lakes because of bacteria, but, ocean is fine. Running, hiking, flying. So things that you wanted to do before, I would say, for the most part, you can.
Yeah, I think that was the part that really surprised me in planning for this episode and speaking with Diane, is just all of the little things that you don't think would impact surgery. Obviously, you want to be mindful of like contamination and germs after any surgery, but just the idea of breathing in something, which makes sense as I'm saying it out loud, but just the idea of the things you can and cannot handle or deal with post surgery just blew my mind. And I'm sure, Diane, we can have a whole separate episode on that. But, what was that process like for you? You received the call that, hey, we're ready for you?
Well, so by the time I got the call for the actual surgery, I had already gone through what's called dry runs. So I had some experience getting these phone calls saying, we have organs for you. Dry runs are just that they prep you, they start doing all the tests and everything. And then ultimately something happens with the organs and the transplant doesn't happen. The day of my transplant, the call came through, and it was really early in the morning. I was having a cup of coffee. My phone rang, and it was a private number, and I knew. I just knew instinctively, this is it. We had about an hour to get to the hospital. So even though, they tell you have a backpack, very similar to like when you're going to have a baby, have a backpack We had that backpack ready to go. There's always last minute stuff. Call so and so. You got to call this person and let them know. And, so we started that process, got to the hospital, and it actually takes quite a few hours between getting the phone call and being brought into OR because there are tests that have to be done. And the preparation for you it's just intense, right? So the sterilization, the cleaning, they sterilize your nose, your mouth, ton, a ton of blood work. I think it was like 90 milliliters of blood work, which is just like 20, 30 tubes of blood that they take, all kinds of stuff. And you just kind of go through the day. You don't really know until the last minute when they say, okay, it's a go, that it's going to happen. And when they do say it's a go, you have like 30 seconds. That's it. They're like, okay, it's time for you to say your byes. We're ready to take you. It's a go. And so before that, you have hours. So Dale and I had plenty of time to have our conversations and our I love yous and thank yous. And this is what you do if something happens type thing. I'm making light of it, but like it really is very serious. We took advantage of that time, just have those conversations because when the team came in to get me, we knew like it's going to be quick. It was the same thing. We had been through the dry runs, so we knew it's like this is our downtime. Let's make sure everything is set up. And so that when they came in, it was just a matter of a hug and a quick kiss and I love you. See you when it's done. Because they come in the room and then they kind of step back into the doorway for a few seconds and then they're moving you. So it's not like they come in and they say, we're going to get you in half an hour. You have time for buys. That doesn't, no, it's like, we got to go. It's happening. So yeah, you have that day, you have those hours to kind of come to terms with what could be happening. And then once you know it's happening, it's all kind of like, here we go, knee jerk type of thing because it's a really quick turnaround. It's pretty wild the way it works out because there's a long lead up time to it. And then when it's time to go, that's it. It's time to go. And it's pretty quick. Yeah.
Sounds like it's a hurry up and wait. And then no, hurry up, let's go, it's go time. There is no more wait kind of exchange or period there.
Yeah, absolutely. That's a perfect description. It's a lot of hurry up and wait. Actually, a lot of the process for transplant is hurry up and wait. Like hurry up and get here. And then you have to wait for the first appointment to get you into rehab. And then hurry up and get your rehab done. Then you have to wait to get listed. So yeah, there's a lot of that. You get really good at dealing with that kind of scenario going through a transplant.
So, Dr. Whitson, what I'm hearing is that for those living with PH, just come in with tons of patience for this experience.
Yeah, it's you spend a lot of time at airports. That's probably good training. Yeah, I agree. So there are preparations that when I was talking earlier about those listing plans, it was took a long time, and when we make a decision as a team to add someone to a transplant list, there are probably 40 people at that meeting, and everyone sort of has their say. And it's the social workers, it's the nutritionists, it's pharmacists, surgeons, and okay, this is something we can tweak and make safer. How can we do that? But in the meantime, outwardly, it seems like there's not a lot going on. I can imagine it's very frustrating.
Yeah, I mean, it's like you said, that airport or flying experience. It's just that we know why we're here. We've gone through dry runs, but it's still an unknown aspect of what's about to happen. So I think just, sharing that out for our audience, just to be mindful if this is the step you're going to take, you're going to go through this process, that it is going to take a moment. You're going to have to hurry up and wait quite a few times throughout this entire process. I kind of want to shift gears a little bit now to post surgery, something that you mentioned earlier about a patient's immune system, what you do after they wake up. You said you suppress their immune system, I believe.
Yeah, we use immunosuppressants. And the way I describe it is you put the immune system to sleep. You don't totally knock it out. And it is sometimes a hard line to walk because occasionally we overdo it, and then obviously not intentionally, but then you've invited infection. And to fight the infection afterward, you have to lighten up on the immunosuppressants. Or you've treated the infection, now there might be some rejection. And so it's sort of this back and forth until you get a couple options of all of the immunosuppressants that we use, 3 different types. So unfortunately, I guess it is not a one size fits all thing. So there are a lot of adjustments that I would say, for the most part, by several months, you've got pretty solid routine down. These are the doses. This dose is too high. Let's, turn it down just a little bit until we find what's well tolerated, but at the same time, we're not putting someone at risk for infection or rejection. So it's kind of keeping things just so.
Also leads to the next question for me. Is this part of that follow-up care? How do you help to manage that risk of rejection and any other follow-up complications for those after transplant?
It's twofold, I would say, is you're checking lab values. There's a lot of blood work, maybe not 9 miles after the fact, but still a fair amount down the line where you're making sure that the levels are right. And so the theory being that if the levels are between P value and B value, okay, and you're pretty well covered against rejection without causing infection. So you try to suppress the different arms of the immune system. And then the other thing we do is screening biopsies, which is really, despite our best efforts trying to find a less invasive way to check it, that's really the only way to check for rejection. Of course, people are sedated for that. Go to pretty good lengths to make sure that people aren't not awake during those biopsies, but making sure that if you have some rejection, which is very common, more common than not really, first year, especially of transplant, that we catch it when it's early, that we can kind of nip it in the bud. It's very treatable without causing that increased risk of infection. So we try to get aggressive about that. And I would say the good thing about transplant in general, regardless of if it's a lung disease, if it's a heart-lung disease, is that it's fairly algorithmic after the hospital stay. So you see folks weekly in clinic to start and needing these biopsies quarterly. And then slowly but surely things improve, medications start to fall off, visits get less frequently. At the end of it all, there's this onus of monthly labs, but you can get those checked at home. Biopsies will end up going to annual, but we'll have folks check their lung function on sort of portable home machines and labs at a local lab core or something like that. So it does become a little less onerous, and that's the upside, but to transplant.
And so we know obviously that everyone's experience will be different, type of after or follow-up care. Diane, what was that like for you when you woke up? You are now post-surgery, and what happens next?
A lot. Yeah, it's a lot. ICU is just mind-boggling with how busy it is. There are people constantly in and out of the room. That's something it's hard to prepare for, but you got to get it in your thought that, in your mind, when you have surgery and you wake up, you're not going to have much privacy as long as you're there. It's just people are in and out, in and out. And it kind of drove me nuts. I was really happy when they said, you're going to step down. It's like, you mean I might sleep? But just because there's so much noise, there's so many people, you really don't get a chance to rest. And like Dr. Whitson said, there's a method to the madness. They're doing that because they're taking care of you and they're on top of everything. And it's very complicated. The first thing when I was extubated was I asked for Dale because I didn't see him. He was out of my eyesight, and saw his hand reach out And then when he stood next to me, the first thing I said to him was, I did it. I was awake and liked breathing. Yeah, it was really intense. And then I don't know, maybe 10 hours later, I was on my feet, walking in place. And it took them, I want to say forever, but I think it was maybe like 15, 20 minutes to be able to get me out of bed because I was connected to so many different machines and all the chest tubes, boxes, and all of that stuff. But it was a slow process. And once I stood up, they just had me march in place. And it felt really good to be standing and moving around. It was, they don't play around. They're like, you got to move. We got to get you out of bed. So, and I was ready. I mean, at one point I tried to walk and I was still on propofol and I tried to get out of the bed and Dale had to hold me down and then they came in and restrained me. And I have a recording of that. Nicole, my other caregiver, she documented everything for me, which is what I asked her to do. So we have a recording of me trying to get out of bed and being quite out of it and just trying to do something. But that's one of the things in rehab. They're like, walk. You have to be able to stand up. You're going to use your legs a lot. You're not going to be able to use your arms because of the incision. So you got to get your legs strong and you have to walk. They're going to make you walk that first day. I don't know, I guess subconsciously that's what was playing out. But it felt good to be able to do that, stand up and walk right after surgery, and then just go through the multitude of teams and it was literally teams of surgeons and physicians that would come in, the lung team, the heart team, endocrinology, infectious disease. Like it was never just one doctor. It was always a group, and just have all the conversations with them and just be prepared to do a lot of talking with a lot of people in IC.
Diane, was there anything that surprised you that you could or couldn't eat, could do physically or couldn't do just to allow your body time to heal and adjust?
There were a couple of things, and no, it shocked me. I just didn't think it would take so much time. I love fresh fruit and salads and all of that stuff, which I can have. I can have on a daily basis if I choose to, but you have to prepare it a certain way. So I can't throw a salad together real quick. It takes a little while. And I was surprised at how long it took. It's like, wait, I have to rinse this. No, I have, and you have to rinse everything separately. And you have to rinse it a certain amount of time with certain temperature water. And so a quick salad became more of a chore in the sense that the prep was different. And then as far as physically, I haven't come across anything that my body has not been able to do yet. And I've pushed it. And that is shocking to me. I mean, I do Zumba. I do a
Yeah.
couple hours every week. I work out every day for a couple hours. I mean, at conference, I dance for 45 minutes with a bunch of people. I can walk, quite a few miles and not get winded. The not getting winded part is still mind boggling to me that I can run up the stairs and not be short of breath, do aerobics and not be a little short of breath because of the exercise that I'm doing, but not the pH short of breaths. A lot of times my legs will be like, please stop before it's my lungs or my heart, it's like
Right.
just,
Right.
I going and it's wonderful. It's a wonderful, wonderful feeling. And I've been able to do a lot more than I thought I was going to be able to do in the first year. It's been really good.
Yeah, I want to also confirm again, Diane is that overachiever. There are definitely things that you pushed yourself to do, but it works for you. You have to be mindful of your body and what level you can have activity post transplant. And I think that's a good point to kind of circle back here. And now for both of you, are there any things you would like to say to our listeners who are considering transplantation as a treatment option? Maybe they've reached this space where they qualify and they're just unsure if they can go through or should go through with it. Any lasting thoughts or advice you want to give to patients and their families listening?
I guess what I would say, the knee transplant is more about quality of life. So the ideal time to need to meet someone when they're considering transplant, want to learn more about it at all, is when they're early. And early meaning it's not necessarily time for a transplant. And the way I think about it is the quality of life, well, maybe not perfect. You really haven't crossed that threshold. So maybe medication doses are going up over a period of time, but you're by and large able to do what you want to do. When I talk to folks about those dozens of medications and the clinic visits and the biopsies, and the thought is, well, yeah, but none of it seems as bad as what I'm going through right now, then I think that's telling. And I think that's probably time to, at a minimum, learn more about it and use resources like Diane, people who've gone through it. Because like I said, I can talk for hours in clinic about it, but I haven't gone through it. You need to hear it from other people. That's one of the great things I think about probably all transplant communities, but this one specifically at Duke that I found with my years here is that everyone is just so willing to help each other and people in similar positions. It's resources everywhere. So it's quality of life. I guess that's what my take home message.
Thank you so much. And Diane?
Yeah, quality of life, that's a big factor. I know for myself personally, that's when that date came, I had gotten to a point where I was wearing a lot of oxygen and very limited on what I could do. And even the oxygen was limited in how much it would help me. So it's been wonderful to be away from that. And deciding to have a transplant is a very personal decision, and everybody has to go through their own emotional process. But to reiterate what Dr. Whitson just said, reaching out and talking to other patients that have been through it is a fantastic way to get firsthand experience and tips and tricks. And patients, we figure out things. It's like, wait, I found a faster way of doing this. So getting that kind of help to begin with to help you learn about it and to make that decision is really invaluable. Take advantage when you go to have your evaluation. They will give you a lot of resources, and take advantage of those resources and just be open to the possibility of your life being able to change in many different ways. It's not a decision to be taken lightly. So give yourself the time you need to make that decision. Talk to who you have to talk to.
Thank you. Thank you so much, Diane. And thank you both for joining me and sharing this information. Hopefully, we helped to answer a lot of questions people may have about it who didn't even consider it or were too afraid or not sure if they should consider as a treatment option. And hopefully, they've taken some information from this call to bring back to their teams to ask those questions, to do some research and determine if it's best for them. I want to, again, thank you both for taking the time out to record this episode. I feel like there's so much more we could explore with this topic, and hopefully we'll begin to do so a lot more through PHA's resources, and we'll become that source for the community listening to be able to truly understand what transplantation means for those living with pulmonary hypertension. Thank you both. I appreciate your time today.
And thank you for listening to PH Insights presented by the Pulmonary Hypertension Association. Remember to subscribe and to join us every second and fourth Wednesday of the month for more valuable insight. Thank you for listening to this episode of PH Insights. We'd like to take a moment to thank our sponsors for their support of the PHA Connects program, which brings you the PH Insights podcast. Sponsors do not participate in the development of and do not endorse content of programming. For a list of our sponsors for 2024, please visit our website at phassociation.org/aboutph/sponsors. Thank you for listening.